Welcome to the webinar, Evaluating Therapeutic Advances in Resource Allocation in Hepatitis-C, Balancing Costs and Patient Factors. This program is provided by North American Center for Continuing Medical Education and is supported by an educational grant from Merck & Company. I'm Eric Cannon with Select Health in Salt Lake City, Utah, and also presenting with me is Dr. Paul Kuo. We will be your presenters today. Here are our disclosures. Our goal in speaking to you today is to quantify the clinical and economic burden of inadequate hepatitis screening and delayed or suboptimal treatment. We will talk about the clinical and pharmacoeconomic profiles of many of the new drugs that are on the market today. And then we will talk about incorporating screening and treatment guidance into our formulary decisions and how we design benefits for members so that we might be able to improve and optimize utilization. So initial diagnostic evaluation for chronic hepatitis C initially starts with an antibody test. Once we have a positive diagnosis and we're ready for treatment, patients should be also vaccinated against hepatitis A and hepatitis B. Making a few points on patient education. Patients should be educated about the spread of the virus and things they can do to prevent the spread. Patients should also be educated about a healthy lifestyle for their livers, and including things that help them achieve and maintain a normal BMI, things about avoiding alcohol. We also have some recent studies that have shown that coffee has positive effects on the liver and can lower, disease progression and reduce the risk of hepatocellular carcinoma. And then finally, I think it's important for us to reinforce for patients that many people with hepatitis C are able to live very normal lives, and that through treatment, and I think that's one of the amazing things with hepatitis C now, we can cure people of this disease. Looking at this next slide and talking about staging according to METAVIR, I think over the last several years there's been a lot of discussion about fibrosis and whether someone's an F0 through F4. This is a great graphic representation of the different stages of fibrosis, everything starting with portal fibrosis at an F1, moving all the way through cirrhosis at an F4. So when the FDA approved the first interferon-sparing treatments for hepatitis C infections, many patients had been previously warehoused, and these patients sought treatment. And we had a situation where the infrastructure and the budgets that we all had could not handle that. And so the AASLD panel offered that we prioritize those most severe patients first. I think what we've seen now is that we've treated most of those patients that have been warehoused. The CDC has since come out with a goal that we eradicate all hepatitis C infection, and so the new guidelines recommend that we treat all patients with chronic HCV infection, except maybe those that have a short life expectancy. And so moving forward, that's the goal, and the guidelines recommend that all patients be treated. There's no consensus on the evidence stating the frequency of someone who is a METAVIR stage F0 moving through, say, F2, or moving from F2 and developing cirrhosis. This is a systematic review of several studies that were pulled together to get us some kind of stage-specific progression rates and estimates. So you can see here that we have estimated prevalence rates now of cirrhosis at 20 and 30 years after infection being 16 and 41% respectively. So what are the long-term benefits of treatment? In this long-term follow-up study, 820 patients were followed for 20 years. I think what's important here is the 15-year survival rate is better in patients with an SVR. You've got 93% that had an SVR. And one of the things that I think is important is absolute survival improved by 5% with treatment. Now, talking briefly about special populations, I think we know that we have different populations that we need to take into account as we're looking at treatments. We know that the prevalence of HCV infection among Black patients is approximately 3 times higher than that's seen among white patients. We also know that Black patients are more likely to be infected with the harder to treat genotypes. And so as we develop our treatment plans, I think that's important. Also looking at concomitant or co-infection with HIV. There's other pieces of that we need to factor into treatment. In the past, as we've had interferon-based treatments, we were very concerned about severe depression and psychiatric syndromes, which are contraindicated with the use of interferons. I think as we've made advances, we haven't had to worry as much about depression and psychiatric syndromes. That said, I think substance abuse is something that we still need to take into account as we're dealing with special populations, whether that's alcohol use or the use of illicit drugs.
Thank you, Dr. Cannon. My goal in speaking to you today is to provide an overview of some of the therapeutic advances in hepatitis C, as well as to discuss some of the resource allocation in hepatitis C. And in particular, we're going to discuss some of the pharmacoeconomics, just to let everybody know that treating hepatitis C really is quite a value when we compare it to other chronic diseases. So first, let's talk about the magnitude of the problem. So across the world, it's not entirely clear, but you can see here that in the United States, there are probably about 3 to 5 million people that have been infected with hepatitis C that may be viremic. And worldwide, the burden is much higher. Some people believe that we may have as many as 170 million people infected. The majority of people are infected with genotypes 1 and 3, which historically have been amongst the most difficult to treat and cure. In the United States, we have predominantly genotypes 1, 2, and 3, with just a smattering of 4 and 6 as well, due to our immigrant population. Compared to other bloodborne diseases, though, hepatitis C is nearly 4 times as prevalent as HIV and hepatitis B. And there is also a considerable gap in the number of individuals who are unaware of their diagnosis. One of the most important things that we need to continue to do is to screen individuals for chronic hepatitis C. So this graph here shows the disease burden of the bloodborne diseases HIV, hepatitis B, and hepatitis C. And the most important aspect of this is that the majority of individuals with chronic HIV infection have already been diagnosed and are aware of their infection. The minority of people with hepatitis B and the minority of people with hepatitis C have been diagnosed with their chronic infection. And while there are other estimates that vary, it's likely that over half of individuals with hepatitis C don't know they have this chronic disorder. This is important because a large part of the hepatitis C epidemic has already occurred. The majority of individuals who have this disorder were infected in the 60s, 70s, and 80s. And because hepatitis C is a disorder that takes often 20 to 30 years to progress to advanced fibrosis, cirrhosis, decompensation, liver cancer, and all of the other complications that we're trying to avoid, right now it appears that the hepatitis C-related cirrhosis prevalence is going to peak over the next 10 years. And this means between 2020, 2030, that we may have as many individuals as 1 million who have hepatitis C and cirrhosis. And these are individuals who are going to require vast resources from the healthcare system, particularly if they have complications. So it's important that we find these individuals by diagnosing their chronic hepatitis C infection and then moving forward with therapy. And as we're going to discuss, hepatitis C therapy is quite effective now and well tolerated. Another aspect of hepatitis C that has changed in the last 10 years is that there is now a resurgence of acute hepatitis C cases in the United States. And this is related to our significant opiate epidemic that we have in the United States. So we have here two maps, and this comes from the CDC MMWR report. But what you can see here is that there are now markedly increased cases of acute hepatitis C. You can see here the Midwest is particularly significantly affected here, and Indiana was a state where there was an epidemic not only of hepatitis C, but also HIV in Scott County. But this epidemic is countrywide, and because of this, we are also seeing a second surge of acute hepatitis C cases and those who are younger, particularly from heroin. And the map on the right just shows that, again, to explain the acute hepatitis C, you can see that there are here deaths from heroin overdose, and this is a county heat map here. And again, you can see that the heroin epidemic, opiate epidemic, goes hand in hand with the chronic hepatitis C prevalence, as well as the acute hepatitis C epidemic that we are now experiencing. Still, the majority of persons chronically infected with hepatitis C are those who were born between 1945 and 1960, the so-called birth cohort group of individuals. And you can see here that for the United States, these individuals comprise approximately 2/3 of the hepatitis C population in the United States. And you can see here on the y-axis here are the number of individuals, and then on the x-axis here is the birth year group. And you can see that between 1945 and 1965, you have a large prevalence of individuals who are chronically infected with hepatitis C. And again, this is because of the risk factors for hepatitis C. Please also remember that hepatitis C was not diagnosed until, or not discovered until, the late 80s, so that people did not know that injection drug use, intranasal cocaine use, a variety of percutaneous exposures could lead to chronic hepatitis C after acute infection. And the majority of these individuals who are infected are individuals who indeed injected drugs in the 60s, 70s, and 80s, and then got on with their life. One of the unfortunate aspects of hepatitis C is that unlike hepatitis A infection in an adult, unlike hepatitis B infection in an adult, you rarely, just a quarter of the time, develop symptoms with acute hepatitis C. So these individuals participated in high-risk behaviors, but the majority of them never had signs or symptoms of chronic hepatitis. Hence, they did not know they acquired this infection, which is why well over half of individuals who are chronically infected with hepatitis C don't know they have the disorder. The AASLD IDSA guidance document recommends right now that patients with ongoing risk factors, and remember, we discussed that we have an ongoing opiate epidemic, and so for individuals who are still injecting drugs or participating in other high-risk behaviors, annual hepatitis C testing is recommended for persons who inject drugs, and also for HIV seropositive men who have unprotected sex with men. So let's briefly talk about the risk of transmission from sexual sources. So heterosexual transmission from hepatitis C is actually quite uncommon. Sex is common, hepatitis C is common. The Centers for Disease Control doesn't really consider hepatitis C to be a sexually transmitted disease through heterosexual transmission. That's different in men having sex with men. And here, the transmission rate can be quite a bit higher, and therefore, HIV seropositive men who have unprotected sex with men need to be tested on an annual basis. Other people with ongoing risk factors should be tested periodically. So how do we go about this? Well, we have, this is the CDC-recommended testing sequence for identifying hepatitis C, and many electronic medical records are trying to incorporate some of this testing algorithm for primary care physicians and other primary care providers, simply because this is how we're going to find this large pool of hepatitis C infected individuals and link them to the necessary care. So we typically start off with a hepatitis C antibody, and if this is non-reactive, we're done. We're going to go into this in a bit more detail shortly. If the antibody is reactive, you then need to order an HCV RNA because remember, when you get hepatitis C, that you become viremic, but approximately 15 to 20% of individuals who acquire acute hepatitis C will actually clear their viremia on their own without therapy. So there is a pool of individuals out there who are hepatitis C positive who never develop the chronic sequelae of hepatitis C because their, if you will, innate immune response was strong enough such that they were able to clear the virus on their own. The majority of individuals will be detected, and these are the people who then need to be linked to care so that these individuals can be appropriately staged to the degree of their liver disease and then subsequently linked to care. So again, this goes to our next statement, which is that all individuals with current hepatitis C infection with viremia should be linked to somebody who is prepared to provide comprehensive management. And there are multiple models of how to care for these individuals: gastroenterologists, hepatologists, infectious disease doctors, as well as primary care providers working with these subspecialists, all have all can provide effective comprehensive management for the hepatitis C. We do need to improve on this. Now, this is a study that was published in the New England Journal, and certainly I think we are making some strides, but this shows the magnitude of the problem that we have. So again, this model that was reported in the New England Journal noted that they estimated 3.2 million individuals with chronic hepatitis C infection. And they modeled that about half of individuals had their hepatitis C detected by antibody tests. So the question is, how many of these individuals had been referred to care? It was about a third of these individuals, or 1 million individuals, and approximately of these individuals, 2/3 of them had an HCV RNA test, and just a smaller percentage, 1/3, had a liver biopsy performed. Now, it's also true that we don't do liver biopsies anymore except under unusual circumstances for hepatitis C. But then we go down to the important part of really diagnosing someone with hepatitis C, which is, can we get these individuals effectively linked to therapy? And you can see here that just 7% of these to 11% were treated. The cure rate at this time was just over 50%. Now this is far greater than that. The cure rate now is approximately 90 to 95%, which is really quite impressive. So I think what we can see is that we're making much greater inroads here. But again, the number of individuals who are successfully linked to care remains low. There have been other studies that shown this, and we need to be able to effectively get these individuals to the correct providers. So if you diagnose somebody with hepatitis C, they should be considered a treatment candidate if they can comply with therapy. This means we're going to now go in and treat individuals that we previously did not treat. And this is important because the previous therapy, interferon, was not effective in about half of individuals, but more importantly, couldn't be tolerated by large numbers of people without comorbidities, and those with comorbidities, heart disease, lung disease, malignancies, they also had interferon contraindicated, as did the individuals with advanced liver disease and advanced liver cancer. Now, some of the populations below we're still not going to treat now. For instance, if you have a bad cardiomyopathy, end-stage chronic obstructive pulmonary disease, cancer, or a life expectancy less than a year, you're not going to treat somebody. But other individuals that we used to exclude from therapy now can be successfully treated. The antibody test is very good. And I've shown this to you in the algorithm. The HCV RNA test detects virus in the bloodstream. And again, we do fibrosis assessments. We don't do liver biopsies anymore. Now, you have to be careful because hepatitis C turns out to be a systemic disease. And this comes from the hepatitis C REVEAL study, which comes from Asia. And what this shows is that hepatitis C causes death by liver disease, by liver cancer. We knew that. But it also causes death by extrahepatic diseases. So on the y-axis is the cumulative mortality. You see 3 graphs here across on the x-axis here. And what you see is that detectable HCV RNA, which is in red, undetectable HCV RNA or no anti-HCV antibody is in blue. But what you can see is, not surprisingly, if you're hepatitis C viremic, your mortality rate is higher. You die of liver cancer at higher rates. But look at the far right graph. Your death rate from extrahepatic diseases is also significantly higher. So hepatitis C replicates more than any other virus in the bloodstream, and therefore it is a disorder that is considered a systemic disease. Regardless of fibrosis, you really need to be treated. Here is the current therapeutic armamentarium. Now, some of these we don't use anymore, but I just list all of the drugs that have been developed against hepatitis C. But you can see here, by creating a combination of what we call direct-acting antiviral agents from multiple classes that target 3 sets of replication proteins in the hepatitis C virus, the NS3, the NS5A, and the NS5B, that we're able now to assemble therapies that cure virtually everybody. And again, there are 2 new ones now, new NS3 protease inhibitors that have been introduced recently, boxilaprovir and glecaprevir, as well as a new NS5A this year, prebrentasvir. Velpatasvir was introduced last year. But the later generation drugs are even more effective, and we are able to cure virtually everybody. And again, I'm not going to go over all the cure rates, except I'm going to take you through just very briefly the cure rates that we have with our current first-line therapies. Now, this guidance is probably going to change in the next few weeks because of the introduction of recent therapies, but the important part is to go over to the 4th column where it says SVR12. That's cure. And look at these, and you can see your cure rates for genotype 1, which has always been historically amongst the most difficult to treat. The cure rates range from 95 to 99.5%. So if you choose any of these therapies for genotype 1, your cure rate is going to be extraordinarily high. Now, this is treatment-naive, non-cirrhotic, but I'm just going to show you for genotypes 2 and 3. Non-cirrhotic, the cure rates go from 95 to 99%. Genotype 4 is above 95%. Genotypes 5 and 6 are also above 95%. And if we add cirrhosis into the mix, by the way, it doesn't really change the overall cure rates that much. There are small slivers of patients who have slightly lower cure rates, but there aren't very many of them. So once you are cured, the other good news is that the complications of these liver-related sequelae of hepatitis C seem to go away. So this is the study that came from the Netherlands, and again, a little bit busy, 4 graphs, but what you can see here is that if you are cured, all-cause mortality, the risk of hepatocellular cancer, liver-related mortality or liver transplantation, as well as liver decompensation, all are markedly reduced when you cure hepatitis C. They don't go away, but they are markedly reduced. And this is very important. The group of individuals who still can get into trouble are those with cirrhosis. And so once you cure somebody, you still have to look after them. But again, those of you who work with patients with cirrhosis know how much the resource content is to care for people with hepatitis C-related cirrhosis once they decompensate. And indeed, this comes from the interferon era, but we're going to cure many more people, and we already have in the DAA era. And so it's important that we find all of these individuals, because there are obviously many benefits from curing those individuals with chronic hepatitis C. And again, this is another slide here that just shows that curing and all-cause mortality after interferon-based therapy improves dramatically. And you can see here that the cumulative mortality from hepatic diseases fell off dramatically, as did the cumulative mortality from extrahepatic diseases as well. Now, what about the cost of these therapies? So these may not be the most up-to-date prices, but this gives you an idea of the relative ratios of the wholesale acquisition costs, or the price for 1 day of therapy. And what you can see here is that the costs of these therapies can be high, but they are starting to fall. So the wholesale acquisition cost for 1 day of sofosbuvir is $1,000, and this is prior to discounts, rebates, and some of these therapies are probably not used in the U.S. so much, but the newer therapies, the wholesale acquisition costs are falling now, and the most recent one that was introduced to the market, clecaprevir, preventosvir, has an approximate wholesale acquisition cost of about $471 per day right now. So you can see here that the prices of these are following. So the question is, of course, what is a cost-effective DAA regimen? And this was a publication that came out last year that looked at a Markov model where they simulated a 1-year cycle length for a cohort of U.S. veterans treated in the VA hospital with untreated genotype 1 hepatitis C. And they looked at the 2 first-line therapies that were approved at the time, sofosbuvir, ledipasvir, ombidisvir, paritaprevir, dasabovir, and they made several assumptions in their model. One is they modeled for only patients with advanced fibrosis or cirrhosis to be treated, and the other one was to treat the people with advanced disease first and then healthier patients 1 year later. And they tried varying treatment, efficacy, price, and duration, and all of these variables, when changed, altered the preferred strategy. One of the most interesting conclusions was that their model demonstrated it's economically unfavorable to restrict treatment to patients with advanced liver disease or to use a staged treatment strategy, and that it's more economically viable to move forward with treating everybody. And here's a table from the paper, and this just showed that the costs, what dominated was cost, and so at the time, the 3D just means paritaprevir, ombidisvir, dasabovir. The cost was $35,560, and this dominated, so that if you get the cost to a sufficient level, treating everybody turns out to be a effective way to treat hepatitis C. And again, we're talking about cost effectiveness compared to other chronic diseases in the United States. And as you know, we usually say the cutoff is $50,000 to $100,000. And here you can see here that the costs came in well within that realm. So again, we want to be able to improve now our linkage to care so that we can treat these individuals. So we're going to need to screen them and then communicate and effectively make sure these individuals are linked to care. Again, once we treat these individuals, unlike the lower treatment rates that I showed you, we now have cures available that can cure essentially 95% or higher. And remember, hepatitis C can be eliminated. There's no non-human reservoir. We have accurate and simple diagnostic tools. Transmission with education can be prevented. And once you're cleared, you're cleared. Hepatitis C is like a light switch. It's either on or it's off. Why don't we treat? We don't treat because of previous adherence to therapy, but these problems are going away. We can treat people who are actively using drugs now, and there are large studies that have shown this. The contraindications, they're very few at this point. You do need to adhere to therapy. You obviously don't want to treat someone with a low life expectancy. The treatments have previously been undervalued, but compared to other chronic diseases, the value and the cost of hepatitis C now are quite reasonable. And I think you're going to see that a trend where people will have, if you will, access to all of these therapies that first-line therapies that I showed you, and will be able to make available to people who are diagnosed with hepatitis C highly effective therapies. As I showed you, all of these first-line therapies are highly effective when used, and you can use any of them without reservation that you're going to get a cure in your hepatitis C patients. And as I said, there are few chronic diseases that can be cured with such a well-tolerated finite therapy that causes such morbidity and mortality. At this point, I'm going to turn the presentation back over to Dr. Cannon. Thanks so much.
While the incidence of new hepatitis C cases has declined over the last 2 decades, it's still estimated that there will be significant clinical and economic consequences from hepatitis C infections in the next decade. And that's mainly going to be driven by individuals who have had the virus for 10 to 20 years. Kerry McAdam, Marks, and colleagues conducted a large retrospective review of a claims database from a large managed care organization. This was a matched cohort study comparing matched individuals with patients or individuals that don't have hepatitis C. The study gives us a good perspective on the actual costs associated with HCV infections. Incremental costs are shown here. Patients with HCV infection cost $9,600 more per patient per year. Patients with decompensated cirrhosis were almost $28,000 more per year, and patients with hepatocellular carcinoma were $43,000 more per year, and those needing a liver transplant, or finally the end of the progression here, patients needing a liver transplant are $93,000 more per year. Here we've listed the various treatment regimens for hepatitis C. I think we have all become very familiar with the costs of therapy, so I don't want to dwell on this. Of note, though, is the fact that we now have 2 treatments that are pan-genotypic, and I think one of those treatments now has an option for 8 weeks of treatment and has a wholesale acquisition cost just over $26,000. So I think as the market is developed, we continue to see advances in the available treatments, but we also start to see some significant changes in the actual costs of the products. This data from Express Scripts gives us an idea where hepatitis C fits in comparison to other disease states. In 2014, hepatitis C passed HIV in annual cost per member per year. It's approaching what we're paying per member per year for oncology. And then you can also see where it fits in relation to multiple sclerosis. I think as we continue to treat patients and as we continue to see the cost of therapy come down, it'll be interesting to see if these numbers continue at the same trends that we're seeing, or if we'll actually start to see utilization stabilize and the overall cost of treating the disease come down a little bit. So what have plans done, and what are they doing about prior authorization? This is a sample prior authorization form, and I think prior authorization is used to help plans direct appropriate treatment and optimize treatment. I think most plans now, while they're not looking at fibrosis, they are looking at genotyping. They are looking at the duration of therapy that may be appropriate for a particular patient depending on the treatment choice and then the genotype of that patient. So looking at a fictional plan, and as a plan that does prior authorization, I think it's important to review the impact of that prior authorization on a regular basis. So within our plan, this is something that we would typically look at as far as for whom is therapy being denied. And then on the left-hand side here, we have a whole list of other factors that on a regular basis we take into account. So I think within our plan, where we're not really looking at fibrosis scoring right now, we are still looking at what are the national guidelines, what's the published evidence, and then in collaboration with our providers and our employer groups that may be purchasing, what is the direction that we want to go that works best for all of us. Michelle Manos and colleagues conducted a retrospective study of patients receiving treatment with pegylated interferon and ribavirin, and this was done at Kaiser in Northern California. They looked at records from 2002 to 2007 to quantify the short-term cost and utilization impact of achieving SVR. Post-treatment all-cause costs per person per year were $6,300 and $10,000 for the SVR and the non-SVR groups, respectively. When all post-treatment years were considered collectively, the non-SVR group had significantly higher costs overall in each category of cost. So I think as you look at this slide, you can see where total costs, hospital costs, outpatient costs, and pharmacy costs in each category were higher in those patients that did not receive an SVR. So now looking at the cost effectiveness of treatment, this is a decision analytic model that was put together looking at it from a lifetime horizon and a societal perspective. What was found in this modeling was that treating all fibrosis stages compared to treating only F3 and F4 adds 0.73 quality adjusted life years and comes at a cost of $28,000. I think the important number here is the incremental cost effectiveness ratio was $39,000 for quality life year gained. And based on today's standards, we would consider that to be cost effective. At base case drug prices, if we were to treat 50% of all eligible U.S. patients with genotype 1, that cost would be about $53 billion. Now, looking at it a little bit differently, if we achieve a 46% reduction in the drug cost, the ICER for treating all those patients decreases by 48%. Treatment of hepatitis C has many challenges. We know it's a silent disease. In the past, it's required very complex treatment regimens. I think we've achieved many advances, and so the treatment regimens are not as complex. That said, it's still a silent disease, and I think people naturally have a fear of adverse effects. All of these things combined together lead to low adherence. So now looking at adherence and what's the benefit of adherence. This is a study that was done several years ago, was looking at pegylated interferon and ribavirin, and what was found was that if the patient takes 80% of the dose, 80% of the time over 80% of the prescribed treatment regimen, the likelihood of a sustained viral response is significantly improved. I think what that tells us and what that shows us, and even though our treatments have changed, we can still see the benefits of making sure that our patients are adherent to therapy. And I think, within a lot of disease states, our trying to get 80% adherence is pretty much the gold standard in a direction that we want to move towards. So let's talk just briefly about the components of specialty pharmacy. Specialty pharmacy services help patients overcome barriers with the adherence to medication in many disease states, and not just hepatitis C. On this slide, I've put many of the programs associated with specialty pharmacy that help patients achieve that optimal outcome. Everything from administrative assistance to refill reminders to patient counseling. There's been a lot of talk recently about the importance of specialty pharmacy. Vasari and colleagues conducted a retrospective observational pharmacy claims-based study using PBM data between 2007 and 2009. They looked at those patients that received both ribavirin and interferon and who exclusively used a single dispensing channel. What they found was that the patients that were using a specialty pharmacy had a 60% higher likelihood of achieving optimal adherence. A similar study was published in 2009, but found just the opposite of the results of the Vasari study. And what they found was that they had SVR rates of 48% in a specialty pharmacy and 56% in a standard pharmacy. They also found that dose reductions were more frequent at the retail site. I think as we look at treatment today, treatment's changed. I think the other piece that's important is that when this study was done, it was looking at data before we really had strongly developed specialty pharmacies. So specialty pharmacy at the time of this trial was really in its infancy. What does this tell us? And I think this is an important point is, and if you look at the last bullet there, data analytics are critical when evaluating sites of service. And I think each of us, whether we prefer retail pharmacies or specialty pharmacies or pharmacies associated with an integrated delivery system, it's critical for each of us to look at the analytics, look at the adherence rates, look at the levels of education, and find that site of care where we're going to achieve an optimal outcome. Now, looking at adherence to hepatitis C therapy, there's a number of potential reasons why patients using a specialty pharmacy may be more successful at being adherent to therapy when using a specialty pharmacy than using a typical pharmacy. And I think you can see the adherence rates here on the screen. But I think also looking at the fact that within specialty pharmacy, you're getting refill reminders, you're getting support from specially trained pharmacists and nurses. You've got scheduled telephonic follow-up where a nurse, a pharmacist, and a patient can quickly resolve any questions that may exist. And then coordination with prescribers. I think if we look at within our own organization, coordination that can happen between a specialty pharmacy and the clinicians in the clinic is much improved through the specialty pharmacy model. Now looking at the value of integration and looking at an integrated model, I think this is some work that was done at Geisinger, looking at what's the benefit of an integrated clinic. What they found was that they were able to minimize any potential drug-drug interactions. They were able to increase adherence. They were able to provide education, frequent follow-ups, and what they found was that, the overall SVR was 93%. They had 6 relapses, and anyone that had previously failed, in this case 33 patients, they were all able to achieve an SVR. So now looking at some key points on channel of distribution, I think provision of pharmacy services to patients with HCV needs to support the patient and help them achieve an optimal outcome and optimal adherence with difficult therapy. Patients need to be educated and empowered to participate in their own care. They're the ones that need to identify adverse effects that may compromise care, and then have the resources or the ability to communicate that with the people that are helping to treat them. Programs should be designed to support a patient and their adherence to treatment. We need programs that will assist physicians and health plans and employers in meeting both their clinical and financial goals. So in conclusion, optimal therapy for the treatment of hepatitis C improves outcomes and it lowers total medical costs. We've looked at the channel of distribution. I don't know that the exact channel is as important as the services provided, and I think we outlined several of those on the previous slides. We know total cost of care is reduced when we increase our SVR rates. I think we're in an exciting time. New treatments have eliminated many of the challenges of traditional therapy that we've had in the past. We've got 2 new pan-genotypic treatments that are on the market today, definitely going to offer us some advantages. And then if we look at the cost-effectiveness data that we have available today, current treatments are cost-effective for treating all patients. So as we move towards this goal of the CDC in achieving a complete eradication of hepatitis C, we have some good treatments available for us in the future. Thank you very much for attending this webinar. We'll now open up the question and answer session. Good afternoon, and thank you for joining us for today's webinar. My name is Dr. Eric Canna, and I will be your moderator for today's Q&A session. My colleague, Dr. Kuo, will be answering questions with me today. As a reminder, if you would like to ask a question, please type your question into the question box. Before we start with questions, Dr. Kuo, any opening comments you'd like to make?
Well, no, thank you very much. So I would like to just again say that there are few diseases that I think we've encountered in the last 20, 30, 40 years that we've been able to really diagnose and cure, such as we can hepatitis C. And I think that we should really take advantage of this extraordinary effort that was really contributed to by many people over many decades and try to make hepatitis C essentially a rare disease in the United States and worldwide. It's going to take prolonged efforts at screening, diagnosing, linking to care, and then treating, but it is well within our grasp to do this. In addition, the therapies now really are extraordinarily effective, and happily their prices are coming down. They've been coming down a few years, and they recently came down again. So it's really a unique opportunity that I hope the world can take advantage of.
Yeah, you bet. I think that's great, and that leads into maybe our first audience question, which talks about screening and the efforts being made to screen individuals. So let me just say that within our organization, we don't really have a formal process as of yet for screening patients for Hep C, although as clinicians become more and more aware of the birth cohort in that population, I think they're asking more questions. Dr. Kuo, can you touch on screening within your organization, and then maybe talk for a minute about the birth cohort, because that's another question we've got.
Yeah, sure. So that, as we discussed in our presentation, the most important aspect of trying to find and eradicate hepatitis C is to identify a very large pool of patients. And this pool is the group that is born between 1945 and 1965. And back then, this was the era where we didn't yet know that hepatitis C was a bloodborne disease. It was actually not even identified until 1986 to 1987. Prior to that, it was known as non-A, non-B hepatitis, presumed bloodborne, but the risk factors were not discovered yet. And hence, you had a large pool of individuals who injected drugs. You had blood transfusions because we had no diagnostic tests. And this is the group that had a large prevalence and accounts for 2/3 of our current hepatitis C population right now regarding prevalence. So anyone who comes to our clinic between the ages of now 52 up to 72 automatically gets screened for hepatitis C, and we are actually making efforts to try to build this into the electronic medical record. We will also make some efforts through studies, hopefully, to be able to send out reminders to people that they should be screened for this. So we aren't the only group. There's a recent publication showing that you can effectively screen people using an electronic medical record, EMR, with a reminder. And again, it's going to take all of these efforts to try to find these individuals, many of whom likely were not going to be, those that were easily accessed by the current healthcare system.
No, that's great, and I think you bring up an excellent point about the role of the EMR, and I think as we talk about screening and eradication of different disease states, having things built into the workflow that everyone is practicing out of, I think is critical. So we know with the new agents we get cure rates in the high 90s. What about reinfection? Are you seeing reinfection in your practice? And maybe, what kinds of education are you doing with patients to help, prevent re-education or reinfection from happening?
Sure. So we, to date, have had just a sporadic handful of reinfections, and that is likely to be expected as we go into groups that we traditionally didn't treat. There's good data now showing that you can get essentially the same cure rates with treating hepatitis C patients if they can comply with therapy who inject drugs or on opiate substitutions. There is a slightly increased risk of reinfection, and some of the populations are the active injection drug users. Men having sex with men is another population that can be reinfected, so that in addition to diagnosing, linking, and treating these patients, they have to be counseled on harm reduction. In addition, we tell them that once you're cured, congratulations, you're cured. There are no protective antibodies for hepatitis C, so that you can reinfect yourself. That's different than hepatitis A or hepatitis B. If you recover from a hepatitis A or B infection and you make the appropriate protective antibodies, you're not going to get this infection again. That's not true, unfortunately, with hepatitis C. So people can get reinfected if they go out and participate in some of the harmful behaviors that likely led to the hepatitis C infection in the first place. So we do counsel along the way harm reduction, but again, it doesn't dissuade us from treating these people. You have to be able to get these people into therapy, because these are the people who are out there and will likely be spreading the disease. And hence, the patients that we see should be involved in multidisciplinary teams to allow us not only to treat their hepatitis C, but also be sufficiently educated, counseled, and if need be, have resources made available to reduce their risk of reinfection.
No, that's perfect. We've had one question come in about what we see as the role for specialty pharmacy, and I'll take that. I think if we look at specialty pharmacy and we look at specialty pharmacy within the managed care environment, I think specialty pharmacies are critical in that they're delivering a lot of services that we typically haven't seen at a regular retail pharmacy. And I think as we talk about education with the patients and regular follow-up, I know the specialty pharmacy that we own and manage, they're calling these patients multiple times a month while they're going through the course of treatment, making sure they don't have any questions and reinforcing many of the things that Dr. Kuo just talked about. Dr. Kuo, let me ask you a question, and this is more a personal question for me, in that it's something I'm becoming more and more interested in. Now that we have two pangenotypic agents on the market, what do you see as the role of those agents? And do we continue to genotype, or do we just pick one and start treating everyone?
Well, I think for now we continue to genotype, but you raise a very good point, which is that nowadays we can have, as you said, there are two outstanding treatment options that are pangenotypic, glucophobia, Parentosir, and sofosbuvir, velpatasvir, and the treatment efficacy for those two it's just really outstanding. You can certainly make the case that if you are using those exclusively, that you'll need a fibrosis assessment, just because you'll need to know which patients with advanced fibrosis need to be screened for hepatocellular cancer, which ones may need a screening endoscopy for varices, but that you could just offer those individuals treatment without a genotype. We're not quite there yet, but that is something that I think, particularly in resource-poor countries, where you may be able to have just point-of-care testing, if you can demonstrate viremia with these pangenotypic therapies, not knowing the genotype may actually be okay to go ahead and proceed with treatment. Here, we don't have that yet, but that in the future certainly is something that I would not be surprised to see happen. And again, particularly one could foresee this if you're in a country which just maybe has just one or two genotypes where you'll have a therapy that can easily be prescribed.
No, thank you very much for that. I think it's an exciting time for us. You know, the landscape has completely changed in the last few years, and as we continue to get new agents, it continues to change. But I think it's all changing for the better and presenting us with many new opportunities for us to get closer to that CDC goal of eradicating hepatitis C from the country. So with that was our last question. Dr. Kuo, any closing comments before we wrap up? No, other than just, again, there are few diseases that we can cure with such well-tolerated treatments. And I just hope that we can use a unique opportunity such that we can have video conferences like this that reminisce about hepatitis C 10 to 15 years from now. Perfect. Thank you. We would like to thank all of our listeners for attending today's webinar. To be eligible for continuing education credit for today's activity, log on to www.naccme.com, successfully complete the 10-question post-test and evaluation form, and immediately print your documentation of credit. This concludes today's session. Thank you again for joining us.